The Jerry Powell podcast is brought to you by Archstone Foundation. Archstone Foundation, improving the health and well-being of older Californians and their caregivers.
And supported by listeners like you, many of whom have donated on the Jerry Powell fundraising site, which you can find at www.jerrypowell.org, big blue button, or through reviews, stars on your favorite podcasting app. Big thank you. Welcome to the Jerry Powell podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are so fortunate to be joined by one of my former mentors who I've known for 20 years, Holly Prigerson, who is now Irving Sherwood Wright Professor of Geriatrics at Weill Cornell Medical School and Professor of Sociology and Medicine, and Director of the Center for Research on End-of-Life Care. She has conducted a number of landmark studies. There are any number of things we could talk to her about, coping with cancer, etc. We're going to talk to her about prolonged grief disorder today. Welcome to the Jerry Powell podcast, Holly.
Oh, thank you, Alex. My star mentee. It's a pleasure to be here and to finally meet Eric. Yeah.
Well, we got a lot to talk about. Before we jump into the topic, do you have a song request for Alex?
Yes, I do. My song request is Come On Up to the House by Tom Waits.
And why this song?
I like that it's irreverent. I like that it's about suffering. I don't like that it's suffering, but I like that it's sort of a flippant view of suffering, that we all go through trials and tribulations, and try not to take yourself so seriously is sort of the message. And I even like a little dose of pragmatism when they say, come down from the cross, we could use the wood. Yeah. That line just kind of tickled me.
Tom Waits has great lyrics. Yeah. All right, here we go. Well, the moon is broken and the sky is cracked. Come on up to the house. The only things you can see is all that you lack. Come on up to the house. All your crying don't do no good. Come on up to the house. Come down off the cross, we can use the wood. Come on up to the house. Come on up to the house. Come on up to the house. The world is not my home, I'm just passing through. Come on up to the house.
Thank you, Alex.
Thank you.
I do have a question for you. Did you have to learn that this week?
Mm-hmm. I learned that yesterday.
Wow. Very good.
Fortunately, that was much easier than some of the other songs that you were considering. Like Left and Right by, what's his name?
Charlie Puth. Yeah, I love that song.
Right. Great song. Like when he does that with the people from BTS, it's like everything's on the left speaker and then everything's on the right speaker.
That's why that song blew me away, and that's why I was
right. Hard
in the
to do.
car.
I don't think you've done a BTS song, Alex.
No. Yeah, people do. I don't know if you know this, but people do like to kind of tweak me, and they choose intentionally incredibly difficult songs for me to play.
That's why I can never select Alex's song. I would always choose
diva singer song. Like Eric made me sing my Milkshake. Boys to the Yard.
Dan Matlock also loves to give you hard ones, Alex.
He does.
So we're not going to be here talking about all of Alex's songs, but we are here to talk about prolonged grief disorder. And Holly, we got a lot to cover, but I feel like before I can actually understand what prolonged grief disorder is, I feel like I have to have a better understanding of what grief is. And I'd love to hear from you, kind of how do you conceptualize grief?
So grief in a nutshell is wanting what you can't have. Something you love has been, the word bereavement means robbed. And so grief is that yearning and craving and pining for someone or something that you love and you've lost. It's no longer there. And so there, you don't know who you are without this person. You've missed them. You have these pangs of anger and bitterness, like why them? So it's a yearning and a craving and a loss of meaning and identity, bitterness, feeling stunned, shocked, disbelief over what happened. It's a constellation of symptoms that really evoke a feeling of wanting that thing back, because you feel like on many levels you just need that thing to be your best you. So you feel like there's this craving that's a yearning and craving and longing for something loved.
Yeah, I was listening to radio, and there was a discussion about grief and music. And they were talking about how, in some ways grief is it's an expression of love. It's a different type of expression of love. Like we're used to like Valentine's Day, like flowers, you have this person in front of you. But grief is kind of that expression of different type of love.
A lot of people have been saying that, and even some of my most respected colleagues. And I get why people say that, because it's it just feels right. But the reason I don't, I'm not sure I agree with it, is because it's more like a wanting and a craving for something than an attachment. Is an attachment love? It's people who love someone are attached, but is attachment necessarily the same thing as love? That also would make it very difficult to pathologize it, because we show people who have this really strong yearning for someone who's no longer there, like they want to die, they're suicidal, their life is over as they know it. And to call that love means it can never be a barrier to your happiness. It just makes it hard to think of and consider in those terms. And so it's not, I guess you could say it's a form of love, but it's really about attachment and wanting something and seeing that thing as so essential to who you are and who you want to be. And if you want to call that love, that's your prerogative. Yeah. But at extreme levels, that love can be pathological, just like extreme levels of sadness or extreme levels of anxiety can reach really extreme levels where it's normal and natural, but it's problematic for a healthy adaptive adjustment.
Yeah. So, I often think about grief as like you have this, in some ways, like an adaptive response to something that was important to you. And it's interesting because, I think back to my own past grief reactions. And sometimes like there's a yearning for the grief, right? There's a yearning for this desire to feel something about something that you've loved so much in the past.
That is so insightful. And because that is what I think people don't get, that, right? Is that a lot of the fear that bereaved people have who get stuck in grief is they're afraid they're going to forget that person.
Yeah, because in truth, your emotion may be the only thing you still have left of that person.
And they don't want to give that up. That's the love. That's all the wonderful feelings that they had. And also it's a little bit of an insult to one's identity to feel like if this special person in your life can be forgotten, then you can be forgotten. It's sort of this egotistical narcissistic concern, you could say, but that's an underlying fear that I think a lot of bereaved people have, that I don't know that many would acknowledge. That it's almost like in Israel there's Yad Vashem, like never forget what happened with the Holocaust. People worry about forgetting, so so they almost feel a need to enshrine or pay homage to this person to make sure that they won't forget this person. And we actually have developed some tools that help people do that, so that they can compartmentalize and feel like they're paying respects and maintaining a continuing bond is often a way people talk about it, but our living memory home is a way to both maintain that connection, because that's the fear, is that you're going to lose this connection to this very special person, and you just feel like all of our humanity is being minimized if you can just forget about this very special person in your life.
I guess that goes on
to lots of ideas, but that was very insightful. So.
Occasionally I'll have an insightful thought. Very occasionally.
All right, so then we can move on.
We can move on, because that's all I got here.
All right.
Well, I guess the other question is, like, when you have these grief reactions, you're talking about specific things that we could potentially do. Is there a wrong or right way to grieve? Is there...
No, there isn't. And I think another narcissistic insult, however, is that there are not patterns to the way most people grieve.
Yeah.
So that's in terms of controversy.
Yeah. So I remember, Homer Simpson, I always bring it up, Simpsons episode, Homer goes through the 5 stages of grief in like 10 seconds. One of my favorite. I'll see if I can find a link and add it to the show notes here. So Kubler-Ross, right? 5 stages of grief. I was taught this in med school. We had to memorize those. That wasn't too long ago. That was 98 when I started med school.
Like, you wouldn't think that was one of the most controversial publications that we ever had, but it was, because what we did was not what people thought that we did. We took out the people who were stuck. So we wanted to answer that question. So in response to what you just asked.
Well, real quick, before you answer what is the 5 stages of grief? Like, can you describe a little bit that for us?
You probably know it. It's the acronym DABDA: disbelief, anger, bargaining. Bargaining, just so you know, is more end of life before the death. So Kubler-Ross was really about people grieving their own death.
Their own death in advance, terminally ill people.
And so the bargaining part was that piece of, if I stop smoking, will my lung cancer go away? Or that kind of, that bargaining. So that bargaining, it's disbelief, anger, bargaining, depression, and then they call it ultimately acceptance. But it's real acceptance is a very, very high bar. We think it's more of a reintegration and recognition that that's how life goes.
And I think I actually got this question wrong in med school. I remember this. I said there are no stages of grief.
Well,
they said I was wrong. Like everybody.
If you were to look on the internet, people even cite our JEM publication that tested it, because there are 2 ways of looking at the results that we got. But
yeah, tell me about real quickly, what did you find in your study?
So just most bereavement experts, assuming we can call ourselves experts anyway, because everyone seems to think that they're an expert in bereavement. That's part of the challenge. Is they don't like to say that everyone follows the same pattern. Yeah. But that said, there are certain things with the stages of grief that are pretty much undeniable. The first is that disbelief, shock, numbness, initial response to the death of someone you love. There's the deer in the headlights reaction. It's pretty hard to debate that. Most people don't feel that way when someone they love they're told that someone they love has died. Also, that like a frog in boiling water, people get used to almost everything, right? People are resilient, by and large, and they adjust over time to anything, even a horrible, significant loss. So the real debate is those inner states. That is there a systematic pattern? And when I think my cat has an opinion.
Your cat can join us too.
About that. And so when we tested it, we examined these indicators over time in people who were not stuck. And we found like the exact sequence that was proposed, that DABDA sequence. And the likelihood that by chance that would happen was like 0.008. So it wasn't random that we found that exact pattern. So on average, does everyone go through those things? Doesn't mean that people can't re-experience yearning at a later date. No, but are there these patterns? Yeah, of course there are these patterns.
I also got, and you could correct me if I'm wrong. Like when I think about the Homer going through 5 stages, you're in numbness, disbelief, then you go to yearning, then you go to anger, then you go to depression, and then you're finally accepting. And I got from your article, it's like people also, while the peaks follow this pattern, people feel a lot of different things. And it just reminds me of the times I've grieved. Like, it's complicated. It's messy. You feel a lot of things, and you may feel a lot of things in the same day.
Oh, absolutely. And, we'll probably get to this. I don't know. But the initial analyses of prolonged grief disorder was I was with psychiatrists, and a lot of them all thought that all the symptoms of distress were basically depression. So we did this factor analysis, and we found out, no, like these yearning, pining, and longing are a separate cluster that loads differently than symptoms of being sad or blue about the loss or feeling anxious, an anxiety cluster. So one of the things I say is that doesn't mean that the yearning and the depression and the anxiety can't co-occur. It's like a fruit basket. In fact, in bereavement, they're likely to all co-occur at the same time. The person who's high on depression is probably also going to be anxious. But what we're saying is that the characteristics of this particular reaction are distinctive from the characteristics of a depressive reaction and or an anxiety reaction, which you might be experiencing these other feelings and emotions and behaviors too, but they're distinct. It's an orange versus an apple. They're both fruit, but they're different.
And then even like 5 years later, you can all of a sudden have an anniversary or something that brings the grief back on, whether it be feelings of yearning,
and
anger.
That's totally normal. And we don't want to pathologize any of that. That's, in fact, with our assessments, we would avoid anniversary. Like we would assess people at the 13th month post-loss, at the 12th month, or not 24 or 25, because that's very well established. I don't know if you guys have experienced it. It hits my mom died of COVID, and last year was the anniversary. And that day, I experienced it firsthand. I was just like pissed. I was just I couldn't concentrate. Like it's like almost this other unconscious level, just like that a year ago, all these things happened, and it really just brings it all back very intensely.
Yeah. So then if grief is one where you have these peaks, there's a slow kind of build up potentially as far as acceptance with these pangs of grief, occasional like worsenings of it with anniversaries or triggers. How does that differ from, is it complicated grief, prolonged grief disorder?
No, well, we've all agreed upon it being called prolonged grief disorder, so we're all talking about the same thing. And
is that the same as complicated grief?
They're the same symptoms. They're the same symptoms, and that also makes it more challenging for people to understand what the distinctions are, because it's really that intense yearning, pining, and searching for this person who's died, which everyone does in the first few months post-loss. But what we found is, so for example, we did an analysis where we got everyone who met criteria at 6 months at the time. And we wanted to know if you were to plot their grief severity over time compared to those who didn't meet criteria, would everyone's just decline over time? And would there be all these sort of false positives if you had picked them out too soon to say, oh, you just hadn't given it enough time? These people are going to get better because everyone's grief gets better over time. No, it really doesn't. These people, you can pick them out at 6 months very reliably. And now, to be conservative, it's 12 months post-loss. These people are stuck. They were higher initially. They're going to be higher later. Their levels of suicidality and suicidal thinking, risk of cancer, risk of dying of a broken heart, Takotsubo syndrome.
Hmm.
That all is significantly elevated in this very, very small subgroup. We say it's about 4% of those who are bereaved, who are from community-based samples. So that it's different. These people, they feel like the rug has been taken out from under them, and they're not getting back their bearings.
Yeah. So let me ask you this. You probably answered this a lot. I always have to look it up. It's DSM-5 now. It's in the DSM-5. What is, if you can summarize, what is prolonged grief disorder? What are the criteria?
The criteria are mostly yearning, pining, and so the death or loss of a significant other, for starters. And we also wanted to start with death because could it be other losses? Honestly, yes. But we want to try to be as conservative as possible. Then it has to be at least a year. We did analyses that compared those who had a delayed reaction, like not high on those symptoms, and then after 6 months or after a year became high, compared to people who were those initial people who were really high and it stayed high. And it didn't really matter how they got to being high on those symptoms. But if they were high on those symptoms at 6 or 12 months post-loss, they were at risk of extremely bad outcomes, like not very significant, controlling for confounders, controlling for depression, PTSD. I mean, I'll try not to talk too much about stats, but they were at risk. So those symptoms were symptoms of yearning after 12 months post-loss, and or preoccupation with thoughts of the deceased, but it's really yearning. And then it had to be, we actually did a bunch of analyses to determine how many of the remaining criterion C symptoms were necessary. And we arrived at 3 of 8 symptoms that included things like identity disturbance. You feel like you don't know who you are anymore, where you fit in to the world. You feel disbelief. You feel a sense of meaninglessness. You feel extreme loneliness. You feel bitter and pangs of sorrow. Emotional pain is how they've phrased it. So it's this. I always wondered whether I'm forgetting an important symptom, but it's mostly meaninglessness, purposelessness, disbelief, yearning, loneliness, lack of purpose.
And then you also have to have, right? It also has to have, it has to be like distressful, like significantly distressful, and or impairing your social, occupational, other important functioning.
Yes. So you did your homework, and yes.
Yeah, I'm looking at it right now.
Because so when people say we're pathologizing normal grief, these are people who are in this really extreme minority subgroup that had stayed that way for at least a year. And these symptoms in and of themselves are very distressing. They feel detached from others. Like the only person they felt they really could connect with is dead. So they're suicidal. So they have to have these distressing symptoms, and they have to be significantly impaired by those symptoms. So by definition, they're dysfunctional symptoms. This isn't normal level grief.
Yeah. And then you also address, right, different cultures, religions have different norms around grief. How did you address that?
So we've actually, because we have the scale, we've assessed grief. There are thousands and thousands of study participants from Taiwan, from China, from Japan, from Australia, New Zealand, like almost everywhere in the globe. People have used the same standardized, uniform and agreed upon metric to assess what grief is. There have been some studies. For example, there was one there's a Nepalese version where certain cultures have different words for some of these emotions. Like some cultures don't even have a word for grief. So you describe yearning. It's like, we don't have a word for that, or we don't have words for bitterness, or the one that's been really challenging has been emotional numbness. People get tripped up on what that means, and it's just what we mean is like they're like physical numbness, or what are you that they trip over that particular symptom, but it's that sense of detachment from living people. So we've validated with some modifications, like throughout there, it's been very well validated through all these different cultures. So that's why when people say, oh, there are all these the cultural manifestations are more sort of man-made or person-made, imposed perspectives on what seems appropriate.
Yeah.
Like in Spain, there's a viuda, or in Indian culture, a wife was expected to annihilate herself on the funeral pyre. So culture imposes a lot of shoulds and woulds and coulds, but in terms of hardwired mammalian, I mean, it's not just humans. There are elephants. There were whales. Apparently, there was a whale a few years ago in the Pacific Ocean whose baby died, or maybe the mother died and the baby was swimming around. Anyway, so mammals form attachments, and that feeling of missing and wanting and needing that person is universal.
So would you say like the emotional reaction tends to have a lot of similarities, but the outward expression, the mourning of grief of the thing you lost, is more the thing that's influenced by cultural norms?
Yeah. Yeah. So mourning is more the cultural like how people engage in mourning practices, whether Jewish people sit Shiva, those are mourning practices. But in terms of the emotional response to loss of something you love, I think, animals feel it and humans feel it, and that's universal.
So do you get a lot of pushback on that? Because there is a lot of intense discussion about how individualized, I guess we were talking about this before with the stages of grief, how individualized it is, how, there is no right way or wrong way. There is, it really depends on the person. Do you get pushback on that?
I get pushback all the time. And what I struggle with is people not, they'll criticize what happened and fault it for lack of evidence when they just haven't looked at the evidence. The evidence was overwhelming. And that's why the DSM committees were universally compelled to feel that it was time that apparently there was more data supporting the distinctiveness and the need for this disorder than there had been for PTSD, for depression, for almost most of the other affective or anxiety related disorders in the DSM. And the reason is there's a highly specific criteria, and we can identify who these people are. This disorder, secondary to bereavement, is the single mental disorder highest risk for suicidal thoughts and behaviors of any other response, including PTSD and depression, which surprises a lot of psychiatrists. These people want to reunite. So an example was last week, someone told me his sister it's been like 5 years since her husband died. And when he was being buried, she started digging next to him she wanted to join him. Her life was over. She wanted to be close to him. And I think what people don't realize is people who are stuck in that state they're not highly functioning. They don't want to go to work. They don't want to interact with their family. They want to stay home and look at pictures, and they just mourn the loss of the life that they loved and had and don't want to go on. So, and they are at risk for a lot of physical and mental and social impairments. So it's not that we are pathologizing or that's a pathological response by definition. So I get stuck with people not.
Why? So you've been building up the evidence for what, decades now,
Mm-hmm.
and there is a lot of evidence. There's clear risk factors for bad outcomes. Why do you think there is so much pushback for this in particular?
People say things like you said. So one of the criticisms is that it's an insult to the dignity of a loving relationship. So that criticism really got me, because it's like, first of all, how the heck would you ever know that? What does that even mean? Like, so that's what I don't like when people just like, it's an insult to the dignity of a loving relationship. Like really,
the pathologizing of grief is an insult, right?
So if
That's
someone in Romeo and Juliet was if someone dies because they're so bereft over the loss of someone they love that they don't want to go on, is that an insult to that person? Or I think if anything, it might even show how devoted they were to that person. Anyway, I mean, that's sort of a silly one, to be honest, because it's a moot point. But what they're getting at is that there's a sense of stigma, and that I think they claim that I've sort of been a tool of a big pharma, that I'm coming up with a new indication for people to throw drugs at.
Yeah.
And what bothers me about that is the way I got into this was the opposite. I was a sociologist among psychiatrists, and tricyclic antidepressants and interpersonal psychotherapy, which is the standard treatment for bereavement-related depression, were working terrifically for that. But they weren't touching these grief symptoms. So I get people who are coming to me saying nothing they worked has helped them.
Yeah.
SSRIs don't help them.
Yeah.
Psychotherapy isn't helping them. They want very specific targeted treatment for these particular symptoms. So I feel frustrated by people thinking that we're like first of all, I have nothing in a bottle that I'm trying to, and not even.
Well, Holly, I got a question. How much of it is like we've all grieved, we've all experienced this normal, somewhat healthy, adaptive response, a loss that's important to us. But few of us have had prolonged grief disorder. Few of us had that more pathological response. So we assume that everybody's going to have that same response of us. And like statements like I said, that it's an expression of love. How much do you think that's playing a role?
I think you hit that on the head. Really? No, seriously, that's...
So I got two today. I got two smart statements.
Did.
One dumb, two smart.
So, no, I think people feel like it's an insult, and everyone's like that. It just seems like it's medicalizing and stigmatizing what's normal, and it's sort of yucking people's yum in a way. And I feel like what people don't realize is even the challenge has been the criteria seems so easy to meet, like yearning for someone who you love, like who doesn't, you could say who doesn't do that. I challenge these people to meet the criteria, because I hear from researchers who are like, these criteria are way, way too strict because no one's meeting that, because it's really hard to be so stuck in your focus on what you've lost that you don't want to, and you can't even engage in the here and now. Yeah. So it's just a different animal. And I think that people are confusing their feelings of grief with what this disorder is.
I want to ask a question about treatment, and that generally we don't screen or assess for things that we don't have treatments for, because there are downsides to screening and, instituting a whole health system-wide policy of assessment. What are effective treatments or do we have any? What's the landscape look like in terms of treatments for prolonged grief disorder?
So I think that the fact that the standard treatments for bereavement-related depression were not working, that led people like Kathy Shear to develop a very specific targeted treatment. It's really an amalgam of a bunch of different approaches, largely cognitive behavioral therapy. But that specifically has proven effective. Richard Bryant in Australia has adapted different versions of it. There are many psychotherapies, and we even developed an online tool when I was at Dana-Farber. I worked with Brett Litz, who had developed de-stress for combat vets who were suffering from PTSD, and we adapted it for people who had lost a loved one to cancer, and that proved effective. It was an online, that was a therapist-assisted intervention, but it did reduce depression, anxiety, symptoms of grief. The pharmacologic, so there are interventions, online interventions. Even we actually have something for people, because you can experience these symptoms before the death, actually, especially with dementia patients.
Yeah.
So we've developed something we call Empower for family surrogates in the ICU who are having these very, very dependent on this person. They can't communicate. And they're in the ICU and they're dying, and then they're being sort of hounded to sign a DNR order. And we were asked by the critical care docs to come up with a psychological intervention to help them sort of hear what was happening. So we target experiential avoidance and distress tolerance in the ICU. We have 6 15-minute modules in the ICU to help with their grief. And we've shown that it's extremely helpful at reducing their grief and the numbness that get in the way of hearing what's happening and making better decisions, which exacerbate problems in adjustment later on. So like, there are established, pretty well published tools and approaches to address it therapeutically, these symptoms of grief.
And for our listeners, just to distinguish what you're just talking about, that wouldn't be prolonged grief disorder. That would be another grief reaction in anticipation of their loved one's death. It's not 12 years after. It doesn't meet the criteria.
It doesn't meet the timing criteria, but one of the biggest risk factors for post-loss prolonged grief disorder is pre-loss prolonged grief levels. So, and we've examined this analytically. Like, if you can reduce the amount of grief and help people adjust to the impending death, that reduces the amount. I mean, even in the stage theory paper, we showed that if they knew longer than 6 months before the death, that would lower the levels of grief intensity post-loss. So it does sort of seem like there is a certain amount of grief work that people do. In fact, people have even applied this to receiving like targeted therapies for lung cancer. One reporter had asked me about people who had grieved their own death and didn't want to try another round of something because they'd already gone through the stages, they'd said, and they just didn't feel like doing that again. So you can have it before.
In pharmacological treatments, have there been any studies?
There have been very, very few. And for better or worse, we've proposed something that I think it kind of tickles a lot of psychiatrists because it sounds kind of crazy. But there's a little bit of a backstory. Okay. So when I was in the psychiatry department at CMHC at Yale, and every other treatment was naltrexone for smoking, for alcohol, for even behavioral things like gambling. And then I moved up to Boston, and I mentioned to Susan Block, maybe it's yearning, it's craving, it's pining for someone. That sounds like an addiction, and that's where you can get into a lot of trouble. And it's like asking to get being beat up by people to say, now love is an addiction and all this stuff.
Mm-hmm.
But there have been studies of the nucleus accumbens activation in the brain when you're shown pictures specifically of the person who died, but not when you're shown, there's not that reward that's triggered when they show pictures of like Oprah or someone else.
Mm-hmm.
And so we've thought that if naltrexone helps reduce cravings for something you're yearning and pining for, maybe that would free you up to explore relationships that you're stuck looking at pictures. No, like put that away.
Mm-hmm.
That's not so rewarding anymore.
Mm-hmm.
Now that would free you, because it's very specific. The thing about prolonged grief disorder that does distinguish it from depression and PTSD, it's very person specific. It's really personal. It's about that person. You think you need that person. So the idea would be to blunt the cravings for that loved one that was sparking all this longing. And I realize that I'm just asking for people to throw darts at
No, the great thing about social media and Twitter, everybody is very nice.
That's right.
Yeah, right.
We all get along everywhere.
Yeah.
It's
never a rude comment. So I don't expect anything will occur.
That's right. I have one more question along those lines. Has anyone tried ketamine? I'm just curious, given its dissociative effects and amnestic qualities.
No, but that sounds possibly as long as it's not contraindicated. And someone, a geriatrician, was actually telling me that ketamine was given to someone who was bereaved and he died.
Oh.
I guess it might be contraindicated if you don't have, like, I'm not the physician here. You guys,
right.
But maybe if an older widower has a heart condition, maybe you don't give ketamine for their grief.
And the other thing that's being increasingly accepted in our culture and tested are psychedelics.
Absolutely. And I don't know if you guys saw that with Nicole Kidman, 9 Perfect Strangers. Yeah. And that was about grief. So
you must have loved that show, Holly, or you had strong opinions of it.
Yeah. But it did. And then I was part of this NIA panel where these guys from IU who have been doing remarkable, like the data were, talk about impressive data. The data were on showing how it was helpful for alcoholism. It was helpful for PTSD. There is a physician that is trialing psilocybin out in I think in LA.
Mm-hmm. Great.
Well, Holly, love all of it. I'm assuming it was just an easy ride to get this into DSM-5. Well, let me ask you this. I'm going to ask you a different question because we only have a couple minutes. If you had a magic wand, you can change one thing about what providers do around this topic of grief and prolonged grief disorder. What would you use that magic wand on?
I would ask them how they're feeling and coping with their loss. And the data actually taught me something, because I was skeptical about this notion of experiential avoidance, that you sort of have to go through it to get beyond it. And you never really fully get beyond it. Grief is upsetting. So there have been some debates about grief, that resilient people don't need to grieve. And there have been some arguments about that. And if you really love someone, then you will be grieving them. So there's no way around it without really experiencing that loss and what that person meant to you. And that's all normal and natural and healthy. It's the people that can't work their way through those feelings are the ones that are likely to be stuck, assuming that they had that really strong emotional bond. So I would ask clinicians to ask about how they're feeling in response to the loss.
Well, Holly, I want to thank you. But before we end, how about we'll turn to Alex for a little bit more of the song.
There's no light in the tunnel, no irons in the fire. Come on up to the house. You're singing lead soprano in a junk man's choir. Come on up to the house. Does life seem nasty, brutish, and short? Come on up to the house. The seas are stormy and you can't find no port. Come on up to the house. You gotta come on up to the house. Come on up to the house. The world is not my home, I'm just passing through. Come on up to the house.
Well, Holly, thank you very much for joining us on this podcast.
My pleasure.
Thank you, Holly.
And thank you, Archstone Foundation, for continuing to support, and to all of our listeners. We'd also like to thank the generous support from our listeners who've donated $250 or more to the Jerry Powell podcast, including
Meg Walhagen, Thomas Quinn, Rochelle Bernacki, Louise Aronson, James Tulsky, Arden O'Donnell, Mike Steinman, Marianne Forcia, Ashok Krishnaswamy, Nancy Lundeberg, Gail Cooney, David Schiffling, Cheryl Phillips, Jessica Ng, Harry Hahn, Elizabeth Chung, Kathy Foley, Rochelle Bernacki, Christine Ritchie, and Lloyd Woolstadt. Thank you very much.